My name is Diviyashree Kasiviswanathan, and today I'll be presenting a case report that describes the need to look beyond traditional risk factors when diagnosing patients. Starting off, my case study will involve a 29-year-old young male with no traditional risk factors for coronary artery disease. But before I get into that, I'd like to take a few moments to describe what medical diagnosis or misdiagnosis is. About 7.4 million patients are misdiagnosed in the ER every year, and the top 5 clinical conditions that are commonly misdiagnosed are listed in this image over here on this slide. Misdiagnosis is often defined as the diagnosis that is delayed or incorrect as detected by subsequent definitive tests or findings, and medical malpractice occurs because of a variety of reasons, which I'll go into in further detail. Starting off is the short patient-physician interaction time, and this is due to the productivity-based compensation model, which involves the fact that physician salaries are based on the number of patients that they see in an hour. So physicians tend to spend less and less time trying to analyze a patient's past medical history, figure out their symptoms and potential treatments and tests to diagnose. Reason is overworking, and in a recent study conducted by the American College of Surgeons, there's a strong correlation between malpractice suits and burnout. Lack of clinical experience leads inexperienced physicians to not have enough knowledge or background to order specific diagnostic procedures that can rule out certain diagnoses. And then obviously confirmation bias can play a role where physicians typically misdiagnose patients with obesity or anxiety or stress or other lifestyle changes rather than carefully inspecting patient symptoms and keeping an open mind. Starting off, moving on with my case report. A 29-year-old male with no traditional risk factors for coronary artery disease is presented to the emergency room with chest discomfort, and his initial EKG showed peaked T waves. His EKG did not meet the criteria for a STEMI, and his initial troponin level was 0.1 nanograms per milliliter, but then it rose up to 4 nanograms per milliliter. And troponin is a protein that is found exclusively in your heart muscle, so if it is found in your blood stream at a high concentration, that means that your heart is leaking and that you are experiencing a non-STEMI heart attack. Due to his elevated troponin levels, patient was administered IV nitroglycerin, and since he still felt some residual left arm pain, an EKG was performed again and it showed poor R wave progression. At the cath lab, a coronary angiography revealed a total occlusion of the mid-LAD artery and a significant thrombus or blood clot. After a successful PCI, the blood flow was restored in that LAD, as shown in these two images over here. The patient was then returned and monitored in the CCU for 48 hours, where he was administered dual antiplatelet therapy with aspirin and Plavix, as well as high statin medication and a low dose of a beta blocker and an ACE inhibitor. And the patient was discharged home from the CCU with no complications, and he was advised to follow up with an outpatient cardiology clinic. This patient was suffering from Wellens syndrome, which is a warning sign for acute anterior wall myocardial infarction, and prompt revascularization and adjunctive pharmacotherapy is critical to treat Wellens syndrome. The patient appeared to have met the diagnostic criteria for Wellens syndrome. However, if the medical team had dismissed these apparent symptoms due to the patient's young age and overall good health, then the patient would have been misdiagnosed, and this could potentially lead to delayed admission and life-saving treatment. Thankfully, the team did not rely solely on the traditional risk factors, and they brought the patient to the cath lab in time to save him from a potential MI. Overall, this case just highlights the need for physicians to look beyond the traditional risk factors and consider patient symptoms and prior history for accurate diagnosis. Here are my references. If you guys have any questions, please feel free to reach out to me via email. Thank you guys so much for listening to my presentation. I hope you guys enjoyed. Thank you.